Good afternoon, everyone. I'd like to thank the moderators of the FIS initiative. I have the honor and the pleasure to be the moderator for this discussion with such skilled participants that will certainly help us shed light on the challenges and the new types of funding for the public health system. This is a big challenge for Latin America because the healthcare expenses are growing at a speed that is unmatched by their administrations. So we have to find new ways to tackle these challenges. And this is the subject that will serve as the basis for our discussion. We'll learn from the experiences of other countries. It is very important because Brazil has had a successful experience in its public healthcare system. We'll also hear from Congressman Luizinho, who's been leading important initiatives in the legislative. We'll also share the perspective of the academia and PAHO, which is highly participating in initiatives involving Latin America. So I'd like to start by talking about the challenges of Brazil. And I want to take a twofold approach. First, we have a universal healthcare system, but it involves 24.7% of the GDP with public health. And we know that all the other universal access systems in the world involve a lot more than that. And we have to find a sub-financing for this robust, deeply hierarchized system that has funding from the federal government and states and municipalities. But in spite of that, with over 300 billion reais worth of budget allocated to healthcare services last year, we still face lots of challenges, such as, for instance, catering to the growing healthcare needs of our population. And we have to find more resources for that. And I would like to mention some subjects that will serve as the base for our discussion. The public healthcare system has a different fundraising alternatives, and Brazil has a fiscal renounce policy that is quite large, especially in the healthcare system. Just to give you an idea of numbers, the tax renounce with the income declaration of individuals amounted to 14 billion reais. It's no trivial resources. It has an impact, and we have other methodologies to discuss specific taxations, especially the taxes on alcohol and sweetened drinks, tobacco, and to connect this taxation to a higher funding of the healthcare system. Not only because taxation it has the role of decreasing the consumption of these items that are known to cause damage to health, but also to generate taxes. So we have this challenge in Brazil trying to advance in terms of new ways to do fundraising. But there's another aspect which is possibly very important as well for our discussion: how to make better use of our resources, how to find other alternatives for governmental procurement. Brazil has a very strong model of governmental procurement. The Ministry of Health is a large procurer of medicines, equipment, and payment to suppliers. And that is a fundamental aspect where we have to innovate a lot in terms of the healthcare system of Brazil. And we have a lot to advance in that regard because our system is quite boxed in and not allowing managers to advance with other modalities. And the rest of the world has been sharing risk-sharing modalities and procurement, amortization, extremely high cost therapies, gene therapy, where one single therapy could cost $2 million. So we have to deal with other ways to procure services in Brazil. And the public healthcare system is still too tied to an acquisition model. The Brazilian healthcare system pays everything at once. You cannot amortize the purchase, and that would even allow you to share your risk with the provider of the technology. That is probably a very fertile field if we are willing to make better procurements and make better use of the healthcare resources. As I said, in the case of Brazil, it is the resources are quite small vis-a-vis the demands of the population. So we need to find solutions for that. Brazil did some recent progress. We now have a new bidding law that was published last April that will provide us with some different routes to deal with this challenge of procuring and using better these resources for healthcare. But we have to learn from other healthcare models how they deal with that, not only in terms of funding alone. This budget in Brazil basically comes from Social Security. It is our main source of taxes that fund the healthcare system, but also understanding and using these resources in a more intelligent and innovative manner is probably the way forward if we want to attract more resources to the healthcare system. These are my opening words. I think it's very important to listen to the different initiatives of people who've been through this challenge. We'll have a Q&A session at the end to further our discussions as well. And with that, I'd like to give the floor to Dr. Cristian for his comments. Welcome, Dr. Cristian. It's a pleasure to be with you. I'm sorry, who should start? I'd like to invite Dr. Cristian for his initial remarks. Very well. I'm going to talk about some ideas and how we're funding the transformation of the healthcare system of Mexico and the challenges we had before and after the COVID-19 pandemic. We have to reinforce what do we want to use these funds for. The healthcare model that we want to adopt in Mexico, it's about understanding the limits of the existing models, and we have to build the scope of how and what we want to fund. Mexico in 2018, we wanted to change to a model that was exclusively based, it was previously based on the healthcare funding towards a different model. And up until 2020, there was a fragmented and segmented healthcare system with Social Security and a Seguro Popular system for social protection. The popular insurance, or Seguro Popular, is an important step towards the development of funding and the health outcomes for Mexico. But over time, we have a clearer view of the limits of that system, a system that gives access to services, but generates catastrophic expenditures for diseases, and also a program that provides coverage for 194 interventions with coverage for several classes of drugs and medicines. And this is an example of why I said that this system was based on a rationale of financing purely. And we have an important part of the population that within the package that was funded. For instance, they were funding systemic heart diseases for people under the age of 59, knowing that this is more prevalent above the age of 60. So there were important inequities that they attempted and are still attempting to solve with this new project to transform the healthcare system that aims at decreasing inequalities and that one that's able to implement adequate public policies. In 2016, we had failed in translating this healthcare system into a better system. In 15 years, with the creation of the popular insurance, the expenditures in health increased, and but it was still far from the promised amounts. The public expenditures with health is between 2.8 and 2.9% of the GDP. In Mexico, we had a burden placed on catastrophic expenditures because of that. And the transformation that's proposed as of 2018 was to give access to free of charge drugs and public health services to the entire population. Over 300 abandoned hospitals were found, and we intend to recover the infrastructure. And by abandoned hospitals, I'm talking about hospitals built with equipment, but with no human resources, or with no equipment, and with a general shortage of resources. How can we fund this transformation? Well, we should, with the monopoly that we have had to end the previous monopoly with 4 main companies that would share a purchase estimated to be at around $5 million per year. And with this monopoly, they were advancing now we're advancing towards a consolidated purchase of medicines. And the second element of funding, the second pillar is the fight against corruption. In COVID-19, it affected the region with 45% of the deaths in the world. And it contributed 300,000 people deceased by the end of last year. And the Secretariat of Health published these data in May, has been publishing this data since May 2020. And this is affected by the distribution of the public health system, and this is also connected to funding. The recruitment of 30 to 40,000 new physicians and nurses into the social security system, and another 30,000 into the system. We're talking about recruiting over 40,000 nurses and physicians in a period of 2 months. Mexico surpassed 300% between January and July in terms of budget. He's breaking up. With critical healthcare services. And such as the commitment, we're talking about the commitment of authorities towards the pandemic, and this is also to do with the efforts of the population towards halting the transmission. And with that, we added to that the procurement, the purchase of vaccines for the first group of vaccines. And we know that COVID is going to be an endemic disease that will have to continue to vaccinate the population annually. The funding that involves fighting corruption and the thinking that the transformation of the healthcare system has developed a new model of supplemental health for families. The organization has to integrate the healthcare systems and probably needs an important injection of new resources and to fund this ambitious program. We need a fresh public fund and the capacity to create a reference and counter-reference to use technology and with the capability to solve problems in the region. COVID-19 gives us an opportunity, and we know that, as was the case in Mexico, we have to maintain and consolidate essential services. And a political opportunity that we have to use in society. The academia, its production must also be leveraged by the healthcare system, and the need to find a more universal, well-funded healthcare system. In spite of the growth that we're seeing in the sector, there is the need for us to better prepare our healthcare system for COVID-19 and to give us a different perspective. That we apologize, the speaker is breaking up. To make the Mexican system more efficient and more productive. For the next few months and years. Thank you, Dr. Christian, for your comments. And it's interesting to see that Mexico has a lot of similarities with Brazil when it comes to healthcare funding. It also needs subfinancing for public health and this hierarchization of the chain of care, and Brazil prioritized that as an entry door to primary care, hierarchizing medium and high complexity so that we could have a more rational system with a better delivery of healthcare services. And probably Mexico has several characteristics that are similar to those of Brazil. And during the pandemic, we also saw many similarities in terms of how we dealt with the pandemic, how our administrators dealt with the pandemic, and that certainly had an impact on our outcomes. And certainly, we were left with a few legacies in terms of the need for us to give higher priority to health. One interesting thing that we talked about was, if I'm not mistaken, Mexico does not have a policy to define or to regulate the prices of medicines, and we're probably going to talk about that during the Q&A session. Now, I'd like to give the floor to Dr. Luizinho, if he's available. Sure, I'm here. I had a problem with my video feed though, but yes, I can start. Well, Denizar, it's a pleasure to be here with you and to be here with Cristian Morales, who preceded me, Ramiro Guerrero, to participate in such a brilliant seminar conducted by Professor Villar. I think not only Brazil, but the entire world is...
Good evening, everyone. Thank you for having me for the Innovation Forum, FIS Week. I'm replacing Professor Dr. Denizar, a dear friend. He's just an outstanding person. Denizar was supposed to moderate this discussion. We've had some technical difficulties, and that's because we have a sold-out crowd. So the servers could not accommodate the large number of people that decided to attend. Denizar had a plane to take. He was at an airport, I don't know exactly where. He was at the airport, however, he had to board his plane, and he asked me to replace him. Of course, I'm going to do my best to replace him. I know it's no easy feat to replace him. However, we'll be discussing new means to finance or to fund public health. Financing is an important problem throughout the world. It affects every country in the world. Of course, problems differ between those in Brazil and Colombia or Mexico as far as regulation is concerned. Governance, management, healthcare, all of these things are different. And of course, countries will try to adopt the best model for their countries. These healthcare systems can be regulated, funded, managed, and services can be provided in many different ways. It can be a hybrid system between public and private, it's up to the society to make that definition. Funding, however, is common in all countries. And when we discuss public funding, this is even more troublesome, especially at a time in which we have to include new technologies, digital solutions. When I was a young doctor, way back when, I am a clinician, resources I had available then was a pressure gauge, stethoscope, a hammer to check the patient's reflexes whenever we needed some tests, the most complex tests. Maybe it would have been an ultrasound. There weren't digital and highly complex resources. We had an X-ray, an ultrasound. These were the resources we had back then. Of course, the world has moved a long way. And then there was 1985. What happened then? Bill Gates introduced Windows. It connected the entire world. And new technology advances reached society overall. And the health industry was no different. MRIs keep evolving time and time again. New resources, new technology advances, but someone has to foot that bill. It's not cheap. Patients demand more resources, more technology, and we need the funding to back that up. I have the pleasure and the honor to introduce Representative Dr. Luizinho. He's a state representative from Rio de Janeiro. He's my dear friend. He works in the state or the House of Representatives in Brasilia. He's been a brilliant representative. He comes from my state, and I'm very proud of his work in the House of Representatives. I'm honored to have you here. Professor Ramiro Guerrero. He is the principal of the Economy and Health Institute from the Icesi University in Cali, Colombia. He's an expert in economy and health, and he'll be sharing his opinion with us. How can you combine public policies and limited resources? Welcome, Professor Ramiro. It's an honor to have you. You have the floor to start us off. Good evening. Thank you for being here. I'll be speaking Spanish rather. Thank you for inviting me. Thank you for inviting me to share the funding of health systems in Colombia. I've worked with funding. I worked in Harvard at a center and in several Latin American countries as well. I'd like to start by saying that in the United States, when President Obama was promoting the healthcare reform, one of the advocates of that reform had that motto. It's not how much you pay, it's how you pay. That was the slogan of the campaign. The problem is, again, is not how much you invest, but how you are going to invest. The way you do it is the most important thing. In other words, the US spends twice as much in healthcare than Canada, twice as much than the UK, and I mean per capita. However, in Canada and the UK, health-related results are better. They invest less, but they invest better. That's how it's important to understand very well what the mechanisms are behind these investments. International or universal wisdom as to how to finance a health system. Number one, it's important that the population pay for those services before prepaid services. They wouldn't have to wait for a rainy day because then it would be too expensive. It's important to say that risks should be shared and there should be risks solidarity amongst different groups of people. Solidarity on the part of young people, which are usually healthier, and the elderly that are more prone to diseases. This is what we call risks solidarity. And when there are funds for healthcare, the risks should take into account the different age brackets. At the same time, you can say that this is a lesson learned. Most of the funding should come from public sources, either through taxes or mandatory contributions from Social Security, for example. Having said that, most funding should be public. It doesn't necessarily mean that the provision of services be public. The example I'd like to give you is Colombia, the country I come from. The system was developed some 25 years ago. Most of the funding comes from public sources, but the provisioning or the services are provided by private institutions. When you look at the funding point of view, we are socialists, but as far as services are rendered, we are more market and private initiative prone. That again requires complex regulations, but this is something feasible, regardless of how you organize your health system. Just one payer, public provisioning, or in our case, several funding sources, several providers. So regardless of how you organize it, at the end of the day, you should pay a provider for the services they render. It's an art and a science at the same time. And it's not easy to come up with the ideal solution because any payment system would imply some risk sharing. So providers get paid, primary care doctors receive a fixed amount per inhabitant, per member. There are pros and cons, of course, because that gives doctors and providers the risk. What if you have a pandemic? The Zika virus, for example, was one example. The provider wouldn't be able to withstand this burden. But if you pay them item per item, every surgery, every scalpel, it's very difficult to manage that. So you open the doors for providers to offer and provide more and more services. So there should be, we have bundles, services, packages. So someone with any given diagnostics, we know how much that attention, that full care would require, how much would that cost? So that would be a fixed amount. You have an entire collection of fixed price or package. There's no perfect formula. Providers and human beings overall respond to several motivations. Governance, training are required to make sure services are properly provided. And I would like to conclude my initial remarks by saying that there are certain subjects that are universal as far as funding is concerned, no matter how organized the system is. In Latin American countries, there's a lot of informality. There are contributions. It's not easy. There are parts of the population that live or have informal jobs, and it's not that easy to have their contributing to the system. But we know there are health-related issues related to sugar consumption, alcohol, tobacco. This is interesting from the public health point of view. But you don't get as much contribution from these portions of the population. We were talking before about procurement systems. It's important to understand these players, how you can have access to state-of-the-art drugs, how to regulate prices. That's indeed very important. Colombia has greater reach and sophisticated price cap system for drugs in general. And we must acknowledge that in some cases we need special systems. Rare diseases, they're very uncommon, albeit very expensive. That requires a lot of scientific sophistication, experimental treatments, and remove them from the common system, and they should be provided, or that care should be provided in more specialized units, and there should be more control there. and we have to think about funding for the future. The future of health is a personalized treatment. It's even more difficult to regulate such a system because there's not one price for a drug for an entire market. Every patient will have a specific type of drug depending on their genetic characteristics. So we have to think about the future. It's not clear to anyone, but we have to start thinking about it. Not simply disregarding current challenges and putting focus only in future challenges, of course. Thank you very much.
Thank you, Professor Ramiro. Your lecture was extremely good. It's a very bold model and challenging as well. And it's very positive that we can see and hear the experience of Colombia and see if we can adapt it to Brazil. I'll leave my comments to the end. So right now, I'd like to give the floor to Dr. Luizinho, who is a physician, a medical doctor, and he has a large experience in the healthcare system. And he's also an advocate of the public healthcare system. And he probably has the same concerns as we all do, how to fund this Brazilian healthcare system to make it more available to the entire population. And so that everyone has egalitarian access to high quality medical services. Dr. Luizinho, thank you very much for accepting our invitation. And once again, it is an honor to have you with us. You have the floor. Thank you very much for the invitation, and thank you for the opportunity to be here participating in such a high-level forum with such honorable panelists. Brazil probably has one of the biggest, or maybe the largest universal health system in the world. And I see that in a very concrete perspective. Our Constitution guarantees universal access to health, and that's in the Constitution. So there's no other modality than public funding. In addition to public funding, we also have one of the world's biggest supplemental health services. And I want to mention that one of the main ways to fund public health is to expand supplemental health. Brazil has a large room for expanding supplemental health. 1/4 of our population is covered by supplemental health, and we still have a lot to do. And we can make a lot of progress if we are able to de-bureaucratize and deregulate our supplemental health system and really advance in terms of the services we offer. And I want to clarify that in saying this, obviously the resources that we are able to attract and people that join the supplemental health system will take off the burden of our public health system. The public health system has a very important characteristic in that it is very disseminated and very strong, with a presence of basic care units in every corner of Brazil. Of course, we have our difficulties in terms of preventative health, but it reaches most Brazilians. But we can still expand and strengthen basic healthcare. But for that to happen, we have to organize our system trying to hierarchize procedures. The only universal system that's non-hierarchical is the Brazilian system. The systems of Portugal, Canada, or the UK, you don't have access to a GP or a family physician and any procedures that that physician wants to prescribe. So there's a list of procedures that that physician may prescribe before referring that patient to a specialized care or high complexity tests. We have to hierarchize our systems and organize our expenses if we want to attract funding. If we're able to expand supplemental health and bring more Brazilians into supplemental health, if we're able to maintain our rates, and there is a clear rate saying that each municipality in Brazil has to contribute at least 15 or allocate 15% of its public expenses to health, or 12%. And the dream of our constitution is for the federal government to allocate at least 10% of its expenses to the healthcare system. With the cap, this led to another limitation. This is readjusted by the tax collection plus inflation. So the next year amount is never goes down. It always goes up, but it's not guaranteed by the 10% that we have in the municipalities with 15 and in states at 12%. If we look at the global budget, which is low, but it is enough to provide high quality healthcare services, we have to organize our system. I always like to highlight that we have to look for new ways to find funding. And Denizar was moderating this panel in the beginning, and he mentioned a type of funding that we really like, which is the taxes on alcohol and taxes on tobacco and activities that are really damaging to health. Of course, if you're collaborating to somehow lose your health, you can certainly collaborate a bit more to the public health system. Brazil had effective campaigns in the prevention and treatment of AIDS and in the fight against smoking. We had an effective stop smoking program that initiated years ago, and we still have a lot of ground to cover. We have a system that guarantees access to universal healthcare. The perception of people that actually use this system is better than that of the people who don't use it. Of course, the public health system has its difficulties, as with any other system in the world, but it needs to find new ways in the country. We Brazilians, we can't take any more tax raises in Brazil, and except for the taxes on smoking, drinking, and gambling. We are facing the challenge of legalizing gambling in Brazil. Most of the developed countries in the world have casinos, and our country is currently being taken by betting. People who are soccer fans, like me and you, we watch every soccer game, and there are ads about betting on sports, and these bets do not contribute, not even 1 cent, to fund our healthcare system or social welfare. And by legalizing gambling, we need to redirect the taxes collected from gambling to health. So, Josias, I must reiterate that as a new way of finding funding, I think that we have to advance with supplemental health, taking off the burden from the public healthcare system, also by raising taxes on alcoholic drinks and tobacco, and also on gambling. I think that is the way forward if we are to find new forms of funding our health system. And we also have to hierarchize our system so that procedures are carried out with your specialist, and so that most of the services reach the population, and not every system is available. If you go to a healthcare clinic without even undergoing an ECG, that patient is prescribed in the first visit a cardiac MRI. And we have to organize that, to organize our resources. I have a lot to talk about this subject. It's quite an encompassing subject, but I think that in terms of new contributions, I do not believe in a country with public co-participation, co-payments. I don't think that's right. I don't think we are going to be able to advance towards an individual co-payment, but rather I think that we need to perfect our system, our public health system, based on increasing the number of tax sources without increasing the tax burden on Brazilians. That was really good. Dr. Luizinho, I was listening to your words and thinking about the situation that Brazil is going through. Professor Ramiro, in Brazil, as you know, we are 220 million Brazilians, something in that range. And out of these 220 million Brazilians, 47 million approximately have private health insurance plans. And that is not paid by Brazilians individually as out-of-pocket disbursements. 70% of these healthcare plans are paid for by the companies where these people work. And these companies offer them access to these health insurance plans. The remaining 170 million Brazilians do not have this privilege of having a health insurance plan. They only have access to the public system. And since 1988, with the Brazilian Constitution, the Constitution states that health is a duty of the state and a right of our citizens. So every Brazilian citizen, 220 million citizens, should supposedly have access to this coverage given by the public healthcare system. However, at that time, I believe that the parliament members were not expecting such a boom in technology as we've seen over the course of the past decades. So it's just reasonable to think that they didn't notice that would have a huge impact on public budget and the capacity of the public sector to pay for these medical expenses would certainly be limited. And as we know, they started to increase exponentially the expenses related to medical payments. And what Congressman Luizinho is proposing is that the Brazilian Constitution provided for universal access to healthcare services, where everybody can have access to all health services and full access to healthcare. However, this is absolutely unfeasible in face of our limited resources, which come from the taxes that we as taxpayers pay. So we have this dilemma in that we have a constitution that guarantees access, but there are no resources to pay for that access. And our restrictions are that in addition to granting access, you have to fully offer everything. So all of the technological innovations, regardless of whether they bring about benefits to the population, they have to be offered by Brazil to its citizens. And I'd like to hear from you. And in closing our panel, I'd like to hear how Colombia organized its healthcare system, public and private, if the state has to cover for everything, and if there is a hybrid model where citizens are work as co-payers in their diagnostic tests. I mean, I'd like to hear how you in Colombia were able, if at all, to balance out expenses and inflows when it comes to paying for medical assistance. And I'm not talking about health from the perspective of health prevention. I'm talking about medical assistance and hospitalization costs. So were you able to find a way to deal with that, and something that we could possibly replicate in Brazil, given access to the entire population to high quality medical and hospital services? Thank you. I'll try to answer your question. I don't know of any country that's been able to balance the expenses and revenues. The needs around medical care are increasingly higher due to the demography and also due to technological innovation. As you said very clearly, in Colombia, our system requires each a worker to pay a contribution to a central fund, and each person and their family will choose an insurance company. The central fund will then provide the resources to the insurance company that the person has chosen. And this has this is twofold. If you have a high income, you're going to pay more. And the amount that the insurance company receives does not depend on the income of the insured party. They'll get paid according to the risk incurred by that insured associate. So you were talking about co-payments, and if you have a higher income, you're going to pay more. And there's also a shared risk. If you have a higher risk, then your insurance company gets paid more. And insurance companies can be public, private, and they're typically non-for-profit. And this is the general way the system works. People who are unemployed are subsidized, and also people in need, they're also subsidized. But in Brazil, the demand for services is higher, and also due to the political constitution of Colombia from 1991, the constitution establishes that health is a right. And there's also the concept of integral care, as you mentioned yourself. And that's very hard to manage in the system, because originally there was a package of benefits that were really well designed, but in practice, people started demanding high-tech services that are very expensive and are not always cost-effective. So I have two comments about that. The first one is that it's very important to create a capacity in the country to assess new technologies and to do cost effectiveness analyses. The UK, they were leaders in the world in the creation of NICE, the National Institute for Clinical Excellence. It's an institution in the British system that is dedicated to assessing new technologies and new drugs and establishing if they have a good cost-benefit ratio. And FDA, for instance, is different in that they only analyze if the drug is effective. However, NICE, they assess whether the cost-benefit ratio is good. And based on that, in Colombia, we created the National Institute for Technology Evaluation to define which healthcare technologies contribute to the healthcare systems and which ones do not. Many technologies are expensive but do not contribute much. And that's going to be important for decision makers to use it and rationalize access to new technologies. That's very important. And in our case, it was also important to define how the federal government has transferred to the insurance companies the risk of having to provide these new technologies. And there's an agent in the system that tries to balance out the funding. Of course, it's not easy. The funding system, if you read the news in Colombia, you're going to see that there are constant fights over the insufficient funds, especially those associated with technologies. So we have to be able to assess technologies. And one important thing that Congressman Luizinho said was that we have to organize the services, hierarchize them, where we have primary care, good capacity to provide services in primary care, and only provide higher level services to patients in cases where that's really necessary.
Thank you very much, Professor Ramiro, State Representative Luizinho. We have come to the end of this conference. Very interesting session. Stay safe. See you around. Thank you for sharing all your knowledge with all of us. Have a good night.